Omicron is a variant of SARS-CoV-2 first reported to the World Health Organization by the Network for Genomics Surveillance in South Africa on November 24, 2021. It was first detected in Botswana and has spread to become the predominant variant in circulation around the world. Following the original BA.1 variant, several subvariants of Omicron have emerged: BA.2, BA.3, BA.4, and BA.5.3. Doses of a COVID-19 vaccine provide protection against severe disease and hospitalization caused by BA.1 and BA.2. The immunity effects of BA.2 are similar to those of BA.1. For 3-dose vaccinated individuals, the BA.4 and BA.5 variants are more infectious than previous subvariants, making it likely, as of June 2022, for a new peak in COVID-19 infections to occur. Classification. On November 26, the WHO's Technical Advisory Group on SARS-CoV-2 virus evolution declared pangolineage B.1.1.529 a variant of concern and designated it with the Greek letter Omicron. The WHO skipped the preceding letters nu and 11 in the Greek alphabet to avoid confusion with the similarities of the English word new and the Chinese surname Xi. The name of the variant has occasionally been mistaken as Omicron among some English speakers, due to a lack of familiarity with the Greek alphabet, and the relative frequency of the Latin prefix omni in other common speech. The Gieside project has assigned it the clade identifier GR/484A, and the Next Strain project has assigned it the clade identifiers 21K and 21L, both belonging to a larger Omicron group 21M. Mutations. BA.1. Omicron has many mutations, some of which have concerned scientists. Omicron has more mutations than any previous SARS-CoV-2 variant, with 50 mutations, and approximately 32 of these pertain to the spike protein which most vaccines target to neutralize the virus. Many of the mutations are novel and are not found in previous variants of the virus. The variant is characterized by 30 amino acid changes, 3 small deletions, and 1 small insertion in the spike protein compared with the original virus, of which 15 are located in the receptor binding domain. It also carries a number of changes and deletions in other genomic regions. Additionally, the variant has 3 mutations at the furin cleavage site which facilitate transmission of the virus. History. On November 26, 2021, WHO designated B.1.1.529 as a variant of concern and named it Omicron, after the 15th letter in the Greek alphabet. Omicron was first detected on November 22, 2021 in laboratories in Botswana and South Africa based on samples collected on 11-16 November. The first known samples were collected in Johannesburg, South Africa on November 8. The first known cases outside of South Africa were 2 people who traveled on November 11, one who flew from South Africa to Hong Kong via Qatar, and another who traveled from Egypt to Belgium via Turkey. As of January 6, 2022, the variant has been confirmed in 149 countries. Origin hypotheses. Omicron did not evolve from any other variant, but instead diverged on a distinct track, perhaps in mid-2020. Competing hypotheses are being examined. One origin hypothesis is that various mutations in the Omicron variant, comprising a 9-nucleotide sequence, may have been acquired from another coronavirus, responsible for the common cold. This is not entirely unexpected at times. Viruses within the body acquire and swap segments of genetic material from each other, and this is one common means of mutation. A link with HIV infection may explain a large number of mutations in the sequence of the Omicron variant. Indeed, in order to be affected by such a high number of mutations, the virus must have been able to evolve a long time without killing its host, which can occur in people with a weakened immune system who receive enough medical care to survive. This is the case in HIV patients in South Africa, who represent about 14% of the population. HIV prevention could be key to reducing the risk of uncontrolled HIV, driving the emergence of SARS-CoV-2 variants. One hypothesis to explain the novel mutations is that SARS-CoV-2 was transmitted from humans to mice and mutated in a population of mice sometime between mid-2020 and late 2021 before reinfecting humans. Spread. On November 24, 2021, the variant was first reported to the WHO from South Africa based on samples that had been collected from 14 to November 16. South African scientists were first alerted by samples from the very beginning of November where the PCR tests had S-gene target failure and by a sudden increase of COVID-19 cases in Gauteng. Sequencing revealed that more than 70% of samples collected in the province between 14 and November 23 were a new variant. The first confirmed specimens of Omicron were collected on November 8, 2021 in South Africa and on November 9 in Botswana. Likely Omicron samples had occurred on November 4, 2021 in Pretoria, South Africa. When WHO was alerted on November 24, Hong Kong was the only place outside Africa that had confirmed a case of Omicron, one person who traveled from South Africa on November 11, and another traveler who was cross-infected by this case while staying in the same quarantine hotel. On November 25, one confirmed case was identified in Israel from a traveler returning from Malawi, along with 2 who returned from South Africa and 1 from Madagascar. All 4 initial cases reported from Botswana occurred among fully vaccinated individuals. On November 26, Belgium confirmed its first case, an unvaccinated person who had traveled from Egypt via Turkey on November 11. All 3 initial confirmed and suspected cases reported from Israel occurred among fully vaccinated individuals, as did a single suspected case in Germany. On November 27, 2 cases were detected in the United Kingdom, another 2 in Munich, Germany, and 1 in Milan, Italy. On November 28, 13 cases were confirmed in the Netherlands among the 624 airline passengers who arrived from South Africa on November 26. Confirmation of a further 5 cases among these passengers followed later. Entry into the Netherlands generally required having been vaccinated or PCR tested, or having recovered. The passengers of these 2 flights had been tested upon arrival because of the newly imposed restrictions, after which 61 tested positive for SARS-CoV-2. A further 2 cases were detected in Australia. Both people landed in Sydney the previous day, and travelled from southern Africa to Sydney Airport via Doha Airport. The 2 people, who were fully vaccinated, entered isolation. 12 other travelers from southern Africa also entered quarantine for 14 days, while about 260 other passengers and crew on the flight were directed to isolate. 2 travelers from South Africa who landed in Denmark tested positive for COVID-19. It was confirmed on November 28 that both carried the Omicron variant. On the same day, Austria also confirmed its first Omicron case. A detected Omicron case was reported in the Czech Republic, from a traveler who spent time in Namibia. Canada also reported its first Omicron cases, with 2 from travelers from Nigeria, therefore becoming the first North American country to report an Omicron case. On November 29, a positive case was recorded in Darwin, Australia. The person arrived in Darwin on a repatriation flight from Johannesburg, South Africa on November 25, and was taken to a quarantine facility, where the positive test was recorded. 2 more people who travelled to Sydney from southern Africa via Singapore tested positive. Portugal reported 13 Omicron cases, all of them members of a soccer club. Sweden also confirmed their first case on November 29, as did Spain, when a traveller came from South Africa. On November 30, the Netherlands reported that Omicron cases had been detected in 2 samples dating back as early as November 19. A positive case was recorded in Sydney from a traveller who had visited southern Africa before travel restrictions were imposed, and was subsequently active in the community. Japan also confirmed its first case. 2 Israeli doctors tested positive and entered isolation. Both of them had received 3 shots of the Pfizer vaccine prior to testing positive. In Brazil, 3 cases of the Omicron variant were confirmed in São Paulo. Another 5 are under suspicion. A person in Leipzig, Germany with no travel history nor contact with travelers tested positive for Omicron. On December 1, the Omicron variant was detected in 3 samples in Nigeria that had been collected from travelers from South Africa within the last week. On the same day, public health authorities in the United States announced the country's first confirmed Omicron case. A resident of San Francisco who had been vaccinated returned from South Africa on November 22, began showing mild symptoms on November 25 and was confirmed to have a mild case of COVID-19 on November 29. Ireland and South Korea also reported their first cases. South Korea reported its cases from 5 travelers arriving in South Korea from Nigeria. On December 2, Dutch health authorities confirmed that all 14 passengers with confirmed Omicron infection on November 26 had been previously vaccinated. The same day, the Norwegian Institute of Public Health confirmed that 50 attendees of a company Christmas party held at a restaurant in Norway's capital, Oslo, were infected with the Omicron variant. France has confirmed only 25 cases of the new Omicron variant, but officials say the number could jump significantly in the coming weeks. By December 6, Malaysia confirmed its first case of the variant. The case was a South African student entering to study at a private university. In Namibia, 18 cases out of 19 positive COVID-19 samples that had been collected between 11 and November 26 were found to be Omicron, indicating a high level of prevalence in the country. Fiji also confirmed 2 positive cases of the variant. They traveled from Nigeria, arriving in Fiji on November 25. On December 9, Richard Miago, coordinator of the World Health Organization's Immunization and Vaccine Development Program for Africa, announced that Africa accounted for 46% of reported cases of the Omicron variant globally. On December 13, the first death of a person with Omicron was reported in the UK. On December 16, New Zealand confirmed its first case of the Omicron variant, an individual who had travelled from Germany via Dubai. The first death of a person with Omicron was reported in Germany on December 23 and in Australia on 27 December. By Christmas 2021, the Omicron strain became dominant in the US. On January 3, 2022, South Korea reported the first 2 deaths of people who tested positive post-mortem for Omicron. On March 29, 2022, Omicron subvariant BA.2 became the dominant strain in the U.S. Reactions. Vaccine producers. On November 26, 2021, BioNTech said it would know in 2 weeks whether the current vaccine is effective against the variant and that an updated vaccine could be shipped in 100 days if necessary. AstraZeneca, Moderna, and Johnson & Johnson were also studying the variant's impact on the effectiveness of their vaccines. On the same day, Novavax stated that it was developing an updated vaccine requiring 2 doses for the Omicron variant, which the company expected to be ready for testing and manufacturing within a few weeks. On November 29, 2021, the Gamaleya Institute said that Sputnik Light should be effective against the variant, that it would begin adapting Sputnik V, and that a modified version could be ready for mass production in 45 days. Sinovac said it could quickly mass produce an inactivated vaccine against the variant and that it was monitoring studies and collecting samples of the variant to determine if a new vaccine is needed. On December 7, 2021, at a symposium in Brazil with its partner Instituto Butantan, Sinovac said it would update its vaccine to the new variant and make it available in 3 months. On December 2, the Finlay Institute was already developing a version of Sobrana Plus against the variant. Pfizer hoped to have a vaccine targeted to immunize against Omicron ready by March 2022. World Health Organization. As with other variants, the WHO recommended that people continue to keep enclosed spaces well ventilated, avoid crowding and close contact, wear well-fitting masks, clean hands frequently, and get vaccinated. On November 29, 2021, the WHO said cases and infections were expected among those vaccinated, albeit in a small and predictable proportion. On November 26, 2021, the WHO asked nations to do the following. Enhance surveillance and sequencing efforts to better understand circulating SARS-CoV-2 variants. Submit complete genome sequences and associated metadata to a publicly available database, such as GISID. Report initial cases/clusters associated with virus of concern infection to WHO through the IHR mechanism. Where capacity exists and in coordination with the international community, perform field investigations and laboratory assessments to improve understanding of the potential impacts of the virus of concern on COVID-19 epidemiology, severity, and the effectiveness of public health and social measures, diagnostic methods, immune responses, antibody neutralization, or other relevant characteristics. On November 26, 2021, WHO advised countries not to impose new restrictions on travel, instead recommending a risk-based and scientific approach to travel measures. On the same day, the European Centre for Disease Prevention and Control reported modelling indicating that strict travel restrictions would delay the variant's impact on European countries by 2 weeks, possibly allowing countries to prepare for it. International response. After the WHO announcement, on the same day, several countries announced travel bans from southern Africa in response to the identification of the variant, including the United States, which banned travel from 8 African countries, although it notably did not ban travel from any European countries, Israel, Canada, or Australia where cases were also detected at the time the bans were announced. Other countries that also implemented travel bans include Japan, Canada, the European Union, Israel, Australia, the United Kingdom, Singapore, Malaysia, Indonesia, Morocco, and New Zealand. The Brazilian Health Regulatory Agency recommended flight restrictions regarding the new variant. The state of New York declared a state of emergency ahead of a potential Omicron spike, although no cases had yet been detected in the state or the rest of the United States. On November 27, Switzerland introduced obligatory tests and quarantine for all visitors arriving from countries where the variant was detected, which originally included Belgium and Israel. In response to the various travel bans, South African Minister of Health Joe Faula defended his country's handling of the pandemic and said that travel bans went against the norms and standards of the World Health Organization. Some speculate that travel bans could have a significant impact on South Africa's economy by limiting tourism and could lead to other countries with economies that are reliant on tourism to hide the discovery of new variants of concern. Low vaccine coverage in less developed nations could create opportunities for the emergence of new variants, and these nations also struggle to gain intellectual property to develop and produce vaccines locally. At the same time, inoculation has slowed in South Africa due to vaccine hesitancy and apathy, with a nationwide vaccination rate of only 35% as of November 2021. On November 29, the WHO warned countries that the variant poses a very high global risk with severe consequences and that they should prepare by accelerating vaccination of high-priority groups and strengthening health systems. WHO Director General Tedros Adhanom described the global situation as dangerous and precarious and called for a new agreement on the handling of pandemics, as the current system disincentivizes countries from alerting others to threats that will inevitably land on their shores. CEPI CEO Richard Hatchett said that the variant fulfilled predictions that transmission of the virus in low vaccination areas would accelerate its evolution. In preparation for the Omicron variant arriving in the United States, President Joe Biden has stated that the variant is cause for concern, not panic, and reiterated that the government is prepared for the variant and will have it under control. He also stated that large-scale lockdowns, similar to the ones in 2020 near the beginning of the pandemic, are off the table for now. In mid-December, multiple Canadian provinces reinstated restrictions on gatherings and events such as sports tournaments, and tightened enforcement of proof of vaccination orders. British Columbia expressly prohibited any non-seated organized New Year's Eve event, while Quebec announced a partial lockdown on December 20, ordering the closure of all bars, casinos, gyms, schools, and theaters, as well as imposing restrictions on the capacity and operating hours of restaurants, and the prohibition of spectators at professional sporting events. On December 18, the Netherlands government announced a lockdown intended to prevent spread of the variant during the holiday period. In late December, some countries shortened the typical 6-month interval for a booster dose of the vaccine to prepare for a wave of Omicron, as 2 doses are not enough to stop the infection. UK, South Korea, and Thailand reduced to 3 months, Belgium, 4 months, France, Singapore, Taiwan, Italy, and Australia, 5 months. Finland reduced it to 3 months for risk groups. Other countries continued with a 6-month booster schedule. While antibody levels begin to drop at 4 months, a longer interval usually allows time for the immune system's response to mature. Market reactions. Worry about the potential economic impact of the Omicron variant led to a drop in global markets on November 26, including the worst drop of the Dow Jones Industrial Average in 2021, led by travel-related stocks. The price of Brent crude and West Texas Intermediate oil fell 10% and 11.7%, respectively. Cryptocurrency markets were also rooted. The South African rand has also hit an all-time low for 2021, trading at over 16 rand to the dollar, losing 6% of its value in November. In early December 2021, the chairman of the Federal Reserve, Jerome Powell, testified before the U.S. Senate Committee on Banking that the recent rise in COVID-19 cases and the emergence of the Omicron variant pose downside risks to employment and economic activity and increased uncertainty for inflation. Subvariants. Researchers have detected several subvariants of Omicron and new ones continue to emerge. There are 310 Pango lineages currently associated with the Omicron variant. The standard sublineage is now referred to as BA.1, and the 2 other sublineages are known as BA.2 and BA.3. In mid-2022, BA.4 and BA.5 were detected in several countries. They share many mutations, but also significantly differ. In general, BA.1 and BA.2 share 32 mutations, but differ by 28. BA.1 has itself been divided in 2, the original BA.1 and BA.1.1, where the main difference is that the latter has a R346K mutation. Standard PCR and rapid tests continue to detect all Omicron subvariants as COVID-19, but further tests are necessary to distinguish the subvariants from each other and from other COVID-19 variants. BA.1. Omicron has many mutations, some of which have concerned scientists. Omicron has more mutations than any previous SARS-CoV-2 variant with 50 mutations, and approximately 32 of these pertain to the spike protein which most vaccines target to neutralize the virus. Many of the mutations are novel and are not found in previous variants of the virus. The variant is characterized by 30 amino acid changes, 3 small deletions, and 1 small insertion in the spike protein compared with the original virus, of which 15 are located in the receptor binding domain. It also carries a number of changes and deletions in other genomic regions. Additionally, the variant has 3 mutations at the furin cleavage site which facilitate transmission of the virus. BA.2. A laboratory study on hamsters and mice in Japan published as a non-peer-reviewed preprint in mid-February 2022 suggested that BA.2 is not only more transmissible than BA.1, but may cause more severe disease. This was later disproven by a study in late October 2022, that found BA.2 actually caused less severe disease relative to the original Omicron variant. Therapeutic monoclonal antibodies used to treat people infected with COVID-19 did not have much effect on BA.2, which was almost completely resistant to casirivimab and imduvimab, and 35 times more resistant to sotrovimab than the original BA.1 subvariant. Affected countries and transmissibility. XE. A new BA.1 BA.2 recombinant isolated from the UK in January 2022, dubbed the XE recombinant, was found by the WHO to be potentially 10% more transmissible than BA.2, making it about 43% to 76% to more transmissible than BA.1, and making the XE recombinant the most contagious variant identified. BA.2.12. There were two new BA.2 subvariants detected in the U.S. state of New York, which are BA.2.12 and BA.2.12.1, both of which have a significant growth advantage of 23–27% over BA.2 and contributing to a rise in infections in central New York, centered on Syracuse and Lake Ontario, which later became dominant by May 24 in the U.S. BA.2.75 and BA.2.75.2. The subvariant BA.2.75, first detected in India in May 2022, has been classified as variant under monitoring by the WHO. Additional newer mutations in this line may be capable of escape neutralizing antibodies. XBB and XBB.1. XBB, a recombinant of the BA.2.10.1 and BA.2.75 sublineages, is an Omicron subvariant first detected in August 2022. Described as immune-evasive, it has caused a small surge of cases in countries including Singapore and Bangladesh. On October 20, 2022, the chief scientist of the World Health Organization, Sumaya Swaminathan, warned that the XBB subvariant of Omicron may cause infections in some countries while the severity of the new variants is not yet known. Early observations from Singapore indicated the possibility of XBB being less severe compared to the Omicron BA.5 variant, with data from the first 2 weeks in October 2022 indicating that the XBB variant had a 30% lower hospitalization risk. However, this could also be due to high levels of population immunity from vaccination and previous waves. BA.3. The third Omicron sublineage, BA.3, is very rare. It has the same S gene target failure deletion as BA.1, BA.4 and BA.5. In April 2022, the WHO announced it was tracking the BA.4 and BA.5 subvariants, with BA.4 having been detected in South Africa, Botswana, Denmark, Scotland, and England. Early indications from data collected in South Africa suggested BA.4 and BA.5 have a significant growth advantage over BA.2, which by May 12 earned the status variant of concern by the European Centre for Disease Prevention and Control, and, by May 20, by the UK Health Security Agency. BA.5 was dominant in Portugal by May 25, accounting for 2/3 of all new cases there. By June 24, BA.4 and BA.5 together had become dominant variants in the UK and Germany. These two subvariants became dominant in the United States by June 28. By late June, BA.5 became the dominant subvariant in France, with 59% of new cases linked to it. On May 10, 2022, a case of a new subvariant BA.5.2.1 was reported in California. On July 10, the city of Shanghai reported its first case of BA.5.2.1, in a man who had flown in from Uganda, sparking a new wave of testing. On July 22, the province of Ontario, Canada announced that subvariant BA.5.2.1 overtook BA.2.12.1 as the main variant in circulation in Ontario around July 2. Regeneron is reporting that BA.5.2.1 is the main variant in Australia, Belgium, Brunei, Greece, and Iceland. The Government of Canada is also reporting that in late June and July, of the travelers arriving by air who test positive for COVID-19, a substantial proportion are BA.5.2.1, BQ.1 and BQ.1.1. BQ.1 and BQ.1.1 are new subvariants of BA.5. Transmission in humans. In January 2022, William Schaffner, professor of infectious diseases at Vanderbilt University Medical Center, compared the contagiousness of the Omicron variant to that of the measles. Vaccinated. Natural immunity. Vaccinated or natural immunity. In non-human animals. In February 2022, the first confirmed case infecting a wild animal was confirmed by researchers at Pennsylvania State University in white-tailed deer in Staten Island, NY. Surfaces. Although transmission via fomites is rare, preliminary data indicate that the variant lasts for 194 hours on plastic surfaces and 21 hours on skin, compared with just 56 and 7 hours, respectively, for the original strain. Vaccine effectiveness. In January 2022, results from Israel suggested that a fourth dose is only partially effective against Omicron. Many cases of infection broke through, albeit a bit less than in the control group, even though trial participants had higher antibody levels after the fourth dose. BA.1. Omicron has many mutations, some of which have concerned scientists. Omicron has more mutations than any previous SARS-CoV-2 variant with 50 mutations, and approximately 32 of these pertain to the spike protein which most vaccines target to neutralize the virus. Many of the mutations are novel and are not found in previous variants of the virus. The variant is characterized by 30 amino acid changes, 3 small deletions, and 1 small insertion in the spike protein compared with the original virus, of which 15 are located in the receptor binding domain. It also carries a number of changes and deletions in other genomic regions. Additionally, the variant has 3 mutations at the furin cleavage site which facilitate transmission of the virus. BA.4/5. In May 2022, a preprint indicated Omicron subvariants BA.4 and BA.5 could cause a large share of COVID-19 reinfections, beyond the increase of reinfections caused by the Omicron lineage, even for people who were infected by Omicron BA.1 due to increases in immune evasion, especially for the unvaccinated. However, the observed escape of BA.4 and BA.5 from immunity by a BA.1 infection is more moderate than of BA.1 against studied prior cases of immunity. Immunity from an Omicron infection for unvaccinated and previously uninfected was found to be weak against non-Omicron variants, albeit at the time Omicron is, by a large margin, the dominant variant in sequenced human cases. Vaccine adjustments. As of June 2022, researchers, health organizations and regulators are discussing, investigating, and partly recommending COVID-19 vaccine boosters that mix the original vaccine formulation with Omicron-adjusted parts such as spike proteins of a specific Omicron subvariant to better prepare the immune system to recognize a wide variety of variants amid substantial and ongoing immune evasion by Omicron. Signs and symptoms. A unique reported symptom of the Omicron variant is night sweats, particularly with the BA.5 subvariant. Also, loss of taste and smell seem to be uncommon compared to other strains. A study performed between 1 and 7 December by the Center for Disease Control found that the most commonly reported symptoms cough, fatigue, and congestion or runny nose, making it difficult to distinguish from a less damaging variant or other virus. Research published in London on December 25, 2021 suggested the most frequent symptoms stated by users of the Zoe COVID app were a running nose, headaches, fatigue, sneezing and sore throats. Virulence. As of November 28, 2021, the World Health Organization's update states there is currently no information to suggest that symptoms associated with Omicron are different from other variants. Increased rates of hospitalization in South Africa may be due to a higher number of cases, rather than any specific feature of the Omicron variant. On December 4, 2021, the South African Medical Research Council reported that from 14 to November 29, 2021 at a hospital complex in Tshwane, inpatients were younger than in previous waves and the ICU and oxygen therapy rates were lower than in earlier waves. These observations are not definitive and the clinical profile could change over the following 2 weeks, allowing for more accurate conclusions about disease severity. Excess deaths nearly doubled in the week of November 28, suggesting underreporting, but the level was still much lower than that seen in the second wave in mid-January 2021. On December 12, Director General of the World Health Organization Tedros Adhanom asserted that it was wrong for people to consider Omicron as mild. This is because high exposure to previous infections in South Africa likely affects the clinical course of the new infections. On December 20, 2021, a report by the Imperial College COVID-19 Response Team, based on data from England, found that hospitalization and asymptomatic infection indicators were not significantly associated with Omicron infection, suggesting at most limited changes in severity compared with Delta. On December 22, the team reported an approximately 41% lower risk of a hospitalization requiring a stay of at least 1 night compared to the Delta variant, and that the data suggest that recipients of 2 doses of the Pfizer-BioNTech, the Moderna, or the Oxford-AstraZeneca vaccine remain substantially protected from hospitalization. BA.1 and Delta differences. Omicron BA.1 multiplies around 70 times faster than the Delta variant in the bronchi, but evidence suggests it is less severe than previous variants, especially compared to Delta. BA.1 might be less able to penetrate deep lung tissue. Omicron infections are 91% less fatal than the Delta variant, with 51% less risk of hospitalization. However, the estimated difference in the intrinsic risk of hospitalization largely decreases to 0.30% when reinfections are excluded. BA.1 and BA.2 differences. The risk of hospitalization is the same in BA.1 and BA.2 based on reviews from Denmark, India, South Africa, and the United Kingdom. Norwegian studies show that the amount of virus in the upper airways is similar in those infected with BA.1 and BA.2. Studies from Denmark and Qatar found that after an infection with BA.1, the vast majority of people were well protected against a BA.2 infection, although it is unknown how long this protection lasts. Laboratory studies also show that antibodies for BA.1 generally protect against BA.2. In Denmark, preliminary data found breakthrough rates in people that had been vaccinated that were similar to the breakthrough rates seen for BA.1. An initial study by the UK Health Security Agency found that vaccines afford similar levels of protection against symptomatic disease by BA.1 and BA.2, and in both it is considerably higher after 2 doses and a booster than 2 doses without booster. Because of the gradually waning effect of vaccines, further booster vaccination may later be necessary. Diagnosis. The chance of detecting a case particularly depends on a country's sequencing rate. For example, South Africa sequences far more samples than any other country in Africa, but at a considerably lower rate than most Western nations. Furthermore, it can take up to 2 weeks to return a viral sequence in places with the technical capability, hence solid statistics on confirmed cases lag the actual situation. Denmark and Norway regard cases found by their variant qPCR test, which is relatively fast and checks several genes, as sufficient for counting it as an Omicron, also before full sequencing. PCR testing. The FDA has published guidelines on how PCR tests will be affected by Omicron. Tests that detect multiple gene targets will continue to identify the testee as positive for COVID-19. Gene dropout or target failure has been proposed as a shorthand way of differentiating Omicron from Delta. The variant can also be identified by sequencing and genotyping. BA.1 and BA.2 differences. The risk of hospitalization is the same in BA.1 and BA.2 based on reviews from Denmark, India, South Africa, and the United Kingdom. Norwegian studies show that the amount of virus in the upper airways is similar in those infected with BA.1 and BA.2. Studies from Denmark and Qatar found that after an infection with BA.1, the vast majority of people were well protected against a BA.2 infection, although it is unknown how long this protection lasts. Laboratory studies also show that antibodies for BA.1 generally protect against BA.2. In Denmark, preliminary data found breakthrough rates in people that had been vaccinated that were similar to the breakthrough rates seen for BA.1. An initial study by the UK Health Security Agency found that vaccines afford similar levels of protection against symptomatic disease by BA.1 and BA.2, and in both it is considerably higher after 2 doses and a booster than 2 doses without booster. Because of the gradually waning effect of vaccines, further booster vaccination may later be necessary. Rapid antigen testing. In January 2022, the Medicine and Therapeutic Regulatory Agency Therapeutic Goods Administration of the Australian government found that only one of their 23 approved COVID-19 rapid antigen tests stated that it detected Omicron. In June 2022, the German Federal Paul-Ehrlich Institute published their findings, that most rats detect the Omicron variant. Treatment. Corticosteroids such as dexamethasone and IL-6 receptor blockers such as tocilizumab are known to be effective for managing patients with the earlier strains of severe COVID-19. The impact on the effectiveness of other treatments was being assessed in 2021. Relating to monoclonal antibodies treatments, similar testing and research is ongoing. Preclinical data on in vitro pseudotyped virus data demonstrate that some mAbs designed to use highly conserved epitopes retain neutralizing activity against key mutations of Omicron substitutions. Similar results are confirmed by cryo-electron microscopy and X-ray data, also providing the structural approach and molecular basis for the evasion of humoral immunity exhibited by Omicron antigenic shift, as well as the importance of targeting conserved epitopes for vaccine and therapeutics design. While 7 clinical mAbs or mAb cocktails experienced loss of neutralizing activity of 1 to 2 orders of magnitude or greater relative to the prototypic virus, the S309 mAb, the parent mAb of sotrovimab, neutralized Omicron with only 2-3-fold reduced potency. Further data suggest Omicron would cause significant humoral immune evasion, while neutralizing antibodies targeting the SARS-CoV-2 conserved region remain most effective. Indeed, most receptor-binding motif-directed monoclonal antibodies lost in vitro neutralizing activity against Omicron, with only 3 out of 29 mAbs examined in another study retaining unaltered potency. Furthermore, a fraction of broadly neutralizing SARS-CoV-2 mAbs neutralized Omicron through recognition of antigenic sites outside the RBM, including sotrovimab, S2X259, and S2H97. However, sotrovimab is not fully active against the BA.2 Omicron sublineage, and in early 2022 the Office of the USASBR stopped distributing the antibody treatment to states where BA.2 was dominant. Epidemiology. On November 26, 2021, the South African National Institute for Communicable Diseases announced that 30,904 COVID-19 tests detected 2,828 new COVID-19 infections. 1 week later, on December 3, 2021, the NICAD announced that 65,990 COVID-19 tests had found 16,055 new infections and that 72% of them were found in Gauteng. This province of South Africa is densely populated at about 850 inhabitants per km². Gauteng's capital Johannesburg is a megacity. In November 2021, the transmissibility of the Omicron variant, as compared to the Delta variant or other variants of the COVID-19 virus, was still uncertain. Omicron is frequently able to infect previously COVID-19 positive people. It has been estimated the Omicron variant diverged in late September or early October 2021, based on Omicron genome comparisons. Sequencing data suggests that Omicron had become the dominant variant in South Africa by November 2021, the same month where it had been first identified in the country. Phylogeny suggests a recent emergence. Data from South Africa suggests that Omicron has a pronounced growth advantage there. However, this may be due to transmissibility or immune escape related, or both. Also, the serial interval plays a role in the growth. Detectable changes in levels of COVID-19 in wastewater samples from South Africa's Gauteng province were seen as early as 1723 October. The National Institute for Communicable Diseases reports that children under the age of 2 make up 10% of total hospital admissions in the Omicron point of discovery Chilwell in South Africa. Data on the S gene target failure of sampled cases in South Africa indicates a growth of 21% per day relative to Delta, generating an increased reproduction number by a factor of 2.4. Omicron became the majority strain in South Africa around November 10. Another analysis showed 32% growth per day in Gauteng, South Africa, having become dominant there around 6 November. In the UK, the logarithmic growth rate of Omicron-associated S gene target failure cases over S gene target positive cases was estimated at 0.37 per day, which is exceptionally high. Furthermore, by December 14 it appears to have become the most dominant strain. Without presuming behavior change in response to the variant, 1 million infections per day by December 24 are projected for a 2.5 days doubling time. In Denmark, the growth rate has been roughly similar with a doubling time of about 2-3 days, it having become the most prevalent strain on December 17. Switzerland is not far behind. In Germany, Omicron became the most prevalent variant on January 1. In Scotland, Omicron apparently became the most prevalent variant on December 17. In the Canadian province of Ontario, it became the most prevalent strain on December 13. In the US, the variant appears to have become the most prevalent strain on December 18, growing at 0.24 per day. In Portugal, Omicron had reached 61.5% of cases on December 22. In Belgium, the strain has become the most prevalent on December 25, and in the Netherlands on December 28. In Italy, it had reached 28% of cases on December 20 and was doubling every 2 days, while it became the dominant variant in Norway on December 25. In France, it made up about 15% of COVID-19 cases in mid-December, but around December 27 it had increased to more than 60%. Researchers recommend sampling at least 5% of COVID-19 patient samples in order to detect Omicron or other emerging variants. During January 2022, in Denmark the BA.2 variant grew at 0.10 per day as a ratio to BA.1, and became the dominant strain in week 2, 2022. In the United Kingdom, the BA.2 variant was growing at 0.11 per day as a ratio to BA.1. On January 13, 2022, the BBC reported that the hospitalization rate was higher in the US and Canada than in Europe and South Africa. This was attributed to a combination of a greater number of elderly people than in South Africa, greater prevalence of comorbidities such as hypertension and obesity than in Europe, higher indoor transmission due to the winter, lower vaccination rate in the US than in Europe and Canada, and a possible still high prevalence of the Delta variant, which more often leads to hospitalization. Reported cases. See also: Timeline of the SARS-CoV-2 Omicron variant. COVID-19 pandemic in Africa. COVID-19 vaccination in Africa. COVID-19 vaccination in Botswana. COVID-19 vaccination in South Africa. Variants of SARS-CoV-2. Other variants of either interest or concern: Alpha, Beta, Gamma, Delta, Epsilon, Zeta, Eta, Theta, Iota, Kappa, Lambda, Mu. See Kolo Moyo, scientist who discovered SARS-CoV-2 Omicron.